Good morning, everybody, and hello from Perth, Western Australia. I'm delighted to be with you, and I'm going to talk to you about quality and risk in Australian hospitals. And I am happy to answer any questions when I finish the presentation. So in Australia, we always start our meetings and our presentation with an acknowledgement of the traditional owners of the different areas in Australia. And this particular slide, which is taken in the northwest of the country, up where one of our campuses is, in a place called Broome, which is very famous for pearl farming. Beautiful red dirt, and the beach and the beautiful ocean. So a map of Australia, obviously, and this shows our three campuses from the University of Notre Dame. So up in the top left there, you can see Broome, and that is our smallest campus. Down on the bottom left, you will see Perth, and Perth is the capital of Western Australia. And the university is situated about 20 kilometres away on the water in Fremantle, which I'm hoping you've heard of. And our third campus is in Sydney. And this is Fremantle. It's a beautiful port city. And this here is really a large part of the university that you can see there. It, I suppose, became most well known after we claimed the America's Cup in Newport, Rhode Island in 1983, I think, and then the Cup was defended back here in Fremantle. And at that time, the government really spent a lot of money on upgrading the facilities and these beautiful, beautiful old heritage buildings, which is where the university is situated. That's just a little bit of background on Fremantle and the university. It's a private Catholic university, but we're really here to talk about safety and quality. And essentially, safety and quality in Australia is governed by the National Safety and Quality Health Service. And the NSQHS was developed by the Australian government with the primary aim of protecting the public from harm and improving the quality of how we provide healthcare in Australian hospitals. And there are 8 standards which we must adhere to. So in Australia, all public and private hospitals, any day surgery units, and any public dental hospitals are required to be accredited against all of those 8 standards. And this accreditation cycle is 3 yearly. So each public, private, day hospital and dental practice will be accredited across all 8 standards every 3 years. However, every 18 months, they will need to have, I guess, an interim assessment to make sure that from a quality perspective that they are continuing to provide a high standard of care that reaches the standards. So what I'm going to do is just discuss each of the 8 standards and some of the guidelines that we are required to adhere to for that. Having said that, there's a lot more detail associated with each of these standards and issues that we must comply with. However, I haven't included all that. It's just too much for this presentation. So the first is the clinical governance standard, which is really broad and overarching, and it's really there to ensure that robust systems are in place to maintain and improve the safety and quality of healthcare in your organisation. So it's really about governance systems. It's about ensuring that the workforce has the right qualifications, skill level, that they are appropriately supervised to provide safe and high quality care. Also, that the physical environment meets a certain standard, and that the environment itself promotes safe and high quality care. The second standard is preventing and controlling infections. And once again, a lot of guidelines there to ensure that we support and prevent healthcare associated infections and improve what we call microbial, antimicrobial stewardship. So really ensuring that the prescription and administration of antibiotics is done safely and appropriately. So once again, there are very clear evidence-based systems that we must comply with to prevent and control healthcare-associated infections. So that is anything from hand washing to the prevention of central line infections. We also have guidelines around when we should be prescribing antibiotics, which antibiotics to use, and so that we try and minimize antibiotic resistance. Some of the antibiotics can only be prescribed by a specialist infectious diseases doctor or a microbiologist. And that is done so that we don't indiscriminately prescribe antibiotics for sort of very broad spectrum, heavy hitting antibiotics for a simple infection. So very clear guidelines for us to follow there. It also provides guidelines around how we process and sterilize reusable equipment. So things like scopes for endoscopy or that sort of thing, instruments and devices, and all of that cleaning and sterilisation must meet best practice guidelines. It's all very clearly laid out for us. The third standard is comprehensive care, and that is what looks at the processes to identify patient needs and prevent harm. And underneath that, it includes actions related to falls and falls prevention, pressure injuries, nutrition, mental health, cognitive impairment, and end-of-life care. And I'll spend a little bit more time on this because it is very relevant to what we do. So once again, there are clear evidence-based guidelines there for the prevention and care of patients at risk to prevent, or for the management of a pressure injury if that occurs. There are guidelines around the screening, so pressure injury screening, and how we manage pressure injuries should they occur. There are also guidelines there for wound management, once again, based on best practice. Best practice guidelines also for the prevention of falls. So the use of falls risk assessment tools on admission, after any change in the patient's clinical status, or if they move from one ward in the hospital to another ward or department. It's around the use of minimising restraints, using lighting sensors, treating dizziness and polypharmacy. So we know that the patient who takes more than 5 medications is at a significantly higher risk of falls. So trying to manage that polypharmacy, managing delirium, so early identification of any causes of delirium, whether that be an organic cause, for example, a urinary tract infection, and then minimising harm if a fall does occur. So things like adjusting the bed and the chair heights, as well as management post-fall. So once again, all patients, it is mandated that all patients are screened for malnutrition when they enter hospital, and also each week thereafter. The guidelines also talk about how we manage weight loss. So, and I don't know exactly what the weight loss figure is, but if a weight loss is not intentional and it is more than a certain threshold, then once again, that is a trigger for certain interventions. We need to, as I said, screen for malnutrition, so a malnutrition screening tool, remembering that a high BMI or obesity does not mean that the patient is not malnourished. So looking at nutritional risk factors such as malnutrition and dehydration, dysphagia, any sort of special dietary needs, food intolerances or allergies. And of course, in the critical care environment, there would be very clear guidelines here for you around the management of patients in a critical care environment. Another arm, I guess, of this standard is predicting, preventing, and managing self-harm and suicide. So once again, screening, as you can see, there's a lot of screening for any patient who tells us that they have thoughts of self-harm or suicide, or if they present with an episode of self-harm, mental illness, or acute emotional distress. Once again, we need to screen, assess risk, and there will be clear interventions that are required depending on the level of risk which has been identified. There are also guidelines around how to keep the environment safe. There's also a system for caring for patients with cognitive impairment, and that aims to minimise the risk of harm for people with cognitive impairment or at risk of developing delirium. Also, that the use of antipsychotic medication or other psychoactive medication is in line with best practice. And of course, we know that delirium is very common in the critical care environment. So there are actually guidelines there around trying to promote a wake sleep cycle. I know that that is easier said than done. I have worked in cardiothoracic intensive care, so maybe that one's a bit aspirational, but we try. The other thing is too is making sure that patients who are close to the end of life, that active dying phase is identified as soon as possible, so that we can maximise the opportunities to make sure that the patient and their family have the ability to make decisions around their care at the end of life or towards the end of life. The fourth standard is around blood management. And of course, what we are really trying to do is optimise and conserve the patient's own blood. So using blood salvage techniques intraoperatively, and I'm sure you're very familiar with that, things like the cell saver, where any blood that is suctioned during the operative procedure is filtered and returned back to the patient to minimise the requirement for blood transfusion. We also have a very robust system in Australia around screening any blood donations. So we're quite confident that any donated blood is free from any viruses. Having said that, it is, of course, a very precious resource. and we want to optimise and conserve the patient's own blood, as well as making sure that any blood or blood products are safe. So as I said, we look at strategies to reduce the risks of transfusion and to manage the availability of safety of any blood and blood products that we are storing prior to administration. Partnering with consumers is something that's become really, we hear a lot more of it over the last, I guess, 10 years, but particularly over the last 5 years. There is a saying that we say, nothing about us without us, meaning that what this standard requires us to do is to involve the patient in their care at every level. So this standard recognises the importance of involving patients in their own care and providing clear communication to patients and their families. It's about partnering with patients in their own care to support the delivery of optimal care. And there is a responsibility for that at a local level, meaning that the nurse looking after the patient is required to the best of their ability, and as much as is possible, to include the patient in their own decision-making about treatments that are provided to them. There's also a requirement at a hospital and an organisational level. So this, I sit on a national ethics committee, and certainly when we review clinical ethics applications, a large component of that is making sure that there has been research co-design. So any research that involves patients or patient data, unless we're looking at something like a retrospective audit, then we actually need to include the patients on whether that's a working committee, a working party, or something like that, to ensure that they are included in the research design process. So not just that, but also, as I said, it's about making sure the patients have a voice in relation to the care that they receive. And that can be a bit challenging sometimes, as I'm sure you can understand. Medication safety, well, this is a big one for all of us. So it aims to ensure that medications are safely prescribed, dispensed, administered, and their effects are monitored. And I'm sure this is very similar to you. So it aims to ensure that consumers or patients are informed fully about the medications that they're taking, that they understand what their medication needs are and what their rights are around possibly refusing medication if that's what they choose to do. We have what we call the 5 R's of medication administration. So that stands for the nurse having a responsibility to ensure that the right patient receives the right drug in the right dose, via the right route and at the right time. And if any of those are, I guess, omitted, or they haven't been observed, then we would call that a medication incident and something that needs to be reported. And of course, not every patient where a mistake is made, there is not necessarily harm caused. And of course, in most cases, harm is not the outcome. Having said that, sometimes it is, and that is why we have what we call the 5 R's of medication administration. It is a requirement that a periodic medication reconciliation is undertaken, and that is largely the responsibility of a clinical pharmacist or the patient's doctor, who looks at all of the medications to decide whether all of them are still required, or whether some dosages can be reduced, or whether some medications can be stopped altogether. There's a requirement, a legal requirement here, that when narcotics are administered, and we call these Schedule 8 drugs, so Schedule 8 drugs are all of the narcotics, so they must be checked by 2 nurses. So they must be checked from the locked cupboard, signed out in the register, and both nurses need to go to the patient's bedside, check their identification, check their medication chart, and make sure that the correct dose is being given to the correct patient. We are also, as of, I guess, around 5 years ago, because of the abuse of benzodiazepines, these are called restricted Schedule 4 drugs. And so benzodiazepines, among other drugs, they have also been locked up, and they require 2 signatures to get them out of the cupboard and sign them out and administer them to the patient. And that is because we had a big problem with benzo abuse. Some of the hospitals, the larger new hospitals, in fact, the hospital that my daughter works out is a very new, very sophisticated quaternary hospital, and they use these automatic medication dispensing systems. So I have to be honest and say I've never used one. Certainly when I was working clinically, there was no such thing as automatic medication dispensing systems. And it's fair to say they're not widely used, but I think when you're building big new hospitals, it's a good opportunity to administer these. So these are fingerprint enabled. So there's a very clear ability to be able to track who administered the medication. Some of you may know more about this than I do. My understanding is that the patient details and the medications are loaded into these machines by the pharmacist. And then it is just up to the nurse to enter her fingerprint, which will then allow her access to her patient's medication. She can request what she wants, and then the correct medication and the correct dose is automatically dispensed for her to administer to the patients. And not surprisingly, these automatic systems have significantly improved safety outcomes, but then again, they come at a cost, and as I said, they're certainly not available everywhere. Communicating for safety. So that is really around recognizing that effective communication is critical to the ability to provide safe care. So it's around requirements for handover. And here, those handovers are undertaken at the end of the patient bed. I know you're in critical care, and that's probably where they're done anyway. Certainly that is done here, but also in Australia on general wards, the handover goes from bedside to bedside. So it allows the patient the opportunity to put up their hand and say, well, actually, that's not quite right, or this has happened to me today, but I haven't told anyone about it. So once again, it's another opportunity for the patient to be involved in their own care, to have a say, and to make sure that that is communicated effectively. So there are systems in place to identify that the patient receives the care that's intended for them. As I said, a structured handover, ensuring that critical information is communicated in a timely way. And there are also requirements for how to document in the healthcare record. A lot of our hospitals, unfortunately, are still using paper medical records. The newer hospitals, like the one I was talking about with the automatic medication dispenser, certainly they are all electronic, and that's how we're moving to as well. And the final standard is recognising and responding to acute deterioration. And I guess the background to that is knowing that for many, not all, but for many patients who, for example, suffer a cardiac arrest or decompensate very badly, that there have been triggers and warnings there in the hour at least preceding that. I know that's not always the case, but it's about recognizing that clinical deterioration before it gets to a critical end point. So recognizing promptly and ensuring that appropriate action is taken, and that is for mental or for physical deterioration. So we want to recognize the patient who is deteriorating from a mental health perspective before they do something really serious. So they're the 8 standards that acute hospitals are required to adhere to. And as I said, that is just a very brief overview. There is an enormous amount of information that sits under each of those standards. And the accreditation process is very rigorous and very robust. And if it's normally undertaken, I've been involved in a number of them, and it's normally undertaken over a period of 2 or 3 days, and there will be usually at least 3 assessors, and they will move through different parts of the hospital. They essentially have access to everywhere, to medical records. They can go into theatres, they can stop and speak to staff, they stop and speak to patients, they stop and speak to patients' families, and they gather all of that information. And at the end of that 3-day, they will give you an interim report to say that you are doing well and that they don't have any serious concerns, but there are a couple of small things that they think should be improved. And that is really pretty much the only information you get at the end of the 3 days, and then that full report will come within a fortnight. Now, if there's anything serious that you haven't met there, you will be given a period of maybe 4 to 6 weeks to fix that. And if you don't fix that, if it's a critical aspect of care that you are not complying in, essentially you will not be able to continue as a hospital. Now, I've certainly never worked anywhere where that has happened, but at the end of the day, the government is very serious about making sure that the standard of Australian hospitals is high. So if you don't meet that standard, you are simply not allowed to operate anymore. And I've not heard of that happening, certainly recently. Those standards that we've just talked about are for acute hospitals, but so if you worked in aged care, and I am on the board of a large aged care provider, certainly they are required to adhere to a different group of standards, as does the disability sector, as does mental health. So disability, aged care and mental health all have different standards that they need to comply with. There's a lot of similarity and overlap, however. And I guess that's really all I wanted to say today. I'm happy to answer any questions. One thing I did forget to say is that what we find is that most hospitals have an audit calendar. So over the course of the year, in January, they might be auditing documentation, or in February, they might be auditing antibiotic prescribing. And so knowing that we have a standard we need to comply against, every month there will be a different audit undertaken, I guess as an internal process to just see whether we are complying with the standard. And then, of course, we compare that back to previous audits to see whether we're improving or deteriorating, or if there's something that we need to change. So I'm guessing that there is a lot of overlap between the systems that you use in Colombia and that we use here in Australia. And I'd be interested to hear anything more about it or answer any questions that you may have. So thank you very much.